Hello, class. Welcome to Chapter 4. Today we're going to talk about art of exercise medicine, counseling, and socio-ecological factors. So this chapter is kind of a continuation of Chapter 3. However, we're going to approach this from a more psychology background. So we'll talk about different types of, I guess, motivational interviewing or different tools or theories that you can use to assess where your patient is at before you're working with them and while you're working with them. So, why don't we get into it? All right, so first off, why do we even have the necessity of exercise counseling and coaching? Well, we're dealing with patients with chronic conditions, right? And they will likely need substantially more counseling on exercise in comparison to patients without chronic conditions. So the key role of the medical team that comprises everyone, the doctor, exercise specialist, anywhere they're getting referred, like cardiac rehab, for example, they all have to help the patient be motivated to sustain their exercise program. And this links back to the independence and autonomy that we talked about last chapter. We really want people to continue exercising on their own if they're in a position to do so. And these methods, the psychological methods that we're going to talk about, are crucial for physicians to understand as well. So, depending on their business model and depending on if they have formal training or not, the physicians may or may not elect to engage in counseling services. However, some things do need to happen, whether they choose to, engage in this or not. So, they need to be aware of how to address physical activity and exercise for their patient, how to collaborate with exercise professionals, and then what counseling methods the rest of the healthcare team is using. So, that's why, again, I have mentioned it a couple times in these videos, but it's really encouraging to see how many of you want to go on and become doctors because you will be a very small minority of doctors that actually has some background in exercise and background in understanding exercise and how you can, um, I guess, guide your patients on how to do exercise, how to make better choices for their life in regards to physical activity. So, again, not to say those of you who don't want to do that doesn't mean you can tune this out, but um, yeah, the physicians, you guys have a really special role. And as mentioned in, I believe, chapter 1, patients tend to listen to doctors' opinions a lot more than other people on their healthcare team. So, your words really do matter if there's any doubt about that at all. So why don't we get into it? So we're going to look at a couple of different behavior techniques that are used in exercise counseling. And fun fact, most of these were not developed with the idea of exercise counseling, but like many other theories, or techniques, they just fit very good with the exercise model. So I'm sure you guys have heard of some of these, but maybe some of these you haven't. So let's dive into it with first up, self-efficacy. This was developed by Albert Bandura in the 1960s, and I have a feeling most of you have probably heard this name. If it's not for self-efficacy, then it could be for some of the other things that he developed. A very popular name in the world of cognitive psychology, but um, he called this the social cognitive theory of behavior. And the main point is it assesses the confidence in executing a behavior, assists in detecting insecurity and lack of resilience, and allows exercise professionals the ability to use small successes and goals to improve self-efficacy. So, a lot of this is basically understanding where the patient stands with their confidence. And this is actually a really good tool and a really easy tool to use with your patients. So, an example of this can be something like this. How confident are you that you can walk for 30 minutes, 5 days this week? And usually, these questions will be presented with some type of a visual scale or a Likert scale. Usually, 0 to 10 makes the most sense. And it would be something like, 0, certain I can't do it, 5, 50-50 chance I could do it, and then 10, certain I can do it. And the patient would just have to pick somewhere on that line where they think they are. And then here's another question. How confident are you that you can go outside for a 30-minute walk when it is cold and raining? And same scale below. So what this is really good for is it gets at the nuances of people's confidence and things they can do. So maybe if you have a patient, for example, they would answer, an 8 for the first question. Like they're fairly certain they can do it. However, when the conditions change and it's cold and raining or something else, something not ideal is a part of the question, then maybe they might answer a 2 or a 3. And this is really helpful for you to know as the exercise specialist to help kind of gauge where they're at and how you can address it. So this is just one idea. Okay, next we have the stages of change theory, and this was originally called the trans-theoretical model of behavior. It was developed by Prochaska and Di Clementi in the 1980s, and this assists in ascertaining perspective of patient's state of mind. So, unlike the Bandura one we just talked about, self-efficacy, this isn't exactly a technique, it's more a theory. So, using it is a little different than the one we just talked about, but in general, this says that there are 5 steps that people go through when they're trying to adopt a new behavior. So the first one is pre-contemplation, where they're not aware of the need to change anything. Contemplation, aware and considering the need to change, but they haven't actually done any changes yet. Preparation, preparing emotionally and gathering resources. So maybe, if this is for exercise, they're, gathering resources like, what would be helpful for me? How often would I have to exercise? What would I have to do for exercise? So on and so forth. Action, actively attempting the change, and then maintenance, an established behavior. So we could put an example to this so it's a little bit more clear. Um, I'll refer to something that I did maybe a year or two ago. I decided I wanted to run a half marathon, having, run maybe 2 or 3 miles max in the past. So pre-contemplation, I was seeing different, different maybe videos on social media, or I have a friend who runs half marathons. They were talking about half marathons, and I was thinking, okay, half marathons. So I would be in the pre-contemplation phase at that point. So not super aware of the fact that I wanted to do it, but it's in the back of my mind, right? And then contemplation, it would be, I'm starting to think about it. Well, what would training even look like for this? What kind of races are out there? What would a timeline be? Some contemplating, should I even try or not? Preparation, you're like, okay, you know what? I'm gonna do it. I'm gonna run a half marathon. That's gonna be my goal. So you prepare emotionally for runs that are a lot longer than 2, 3 miles, right? And gather resources. I don't know, do you need something like a running vest to carry water and keys and a phone or something? Or what kind of shoe is the best for you personally when you're running? So you're gathering resources. Maybe you're asking people, what are some good training plans to run this half marathon? And then action, I've actively begun training. I'm following week 1, week 2, and I'm trying to stay consistent. And then it would turn into the maintenance phase if it has been established for at least a couple of weeks. Because as many of us know, maybe you can actually start to do something and then things happen and it doesn't turn into a habit, it doesn't turn into an established behavior for one reason or another. So these are the 5 steps. However, there are some drawbacks to using this as a tool. um so as mentioned, it's not exactly like a tool you can use. Like you can't just place that scale in front of someone and say, okay, what phase are you in right now? It doesn't really work that way. So it's more so a theory describing how people go through the stages of change. It also doesn't help guide the counselor in what to say or do in a given circumstance. So, um, y like for example, with self-efficacy, if someone answered 2 to the cold and rainy question, then that gives you a pretty good guide of, okay, this is what we need to address. This is what we need to figure out. Um, this one does not really give a clear guide on what to do next. And then probably most importantly, it gives the impression that change is linear and sequential. So maybe you guys were, running through this in your mind as I was explaining. Um, it doesn't always go in that order, right? Maybe someone flip-flops from pre-contemplation to contemplation for a very long time and then moves forward. Or maybe they're at the point of action and then I don't know, maybe training doesn't go well, for example, with the half marathon example. Um, and they decide, you know what? I'm not gonna do this. So they fall backwards in that the progression of it. So change is not always linear. And sometimes people go back and forth and then yeah, so basically it's not always accurate to how behaviors are actually adapted by people. And then it also overemphasizes the cognitive aspects of change and underemphasizes the emotional or spiritual aspects of it. So, as we know, what you're thinking about doing in a given moment isn't the main thing that drives people often. Maybe sometimes something emotional happens, like um, maybe someone suffers a heart attack, and then that is what prompts them to start exercising or trying to take care of themselves better. It's not always just oh yeah, logically I should do XYZ because I just had this health problem occur. So that's just another drawback with it. However, not to hit on it too hard, it is a good guide to understand the patient's mindset in a given moment. So that you can use this more as checking in with them. Maybe you can categorize them into these different stages privately and not exactly announce, "Oh, yay, you've advanced to the action state." I don't think that's a good way to use this, but it's an interesting theory regardless. Okay, next we have the self-determination theory. So this was developed by, I don't know how to pronounce it, Deci and Ryan in the 1970s. So this relies on intrinsic motivation instead of extrinsic, which makes it especially well suited for exercise counseling. So a lot of these theories and techniques we're talking about were actually developed to get people to stop smoking. Like, what are some techniques to help them stop this bad habit? But exercise specifically is really well suited for self-determination because exercise provides intrinsic motivation and extrinsic. So in the moment, people usually feel good, especially if they're doing an activity instead of like just walking or running on a treadmill, for example. And people also tend to notice really quickly that they feel good after exercise is done too, which is really nice. So in general, the self-determination theory is a motivational tool to promote exercise and activity adherence. So the goal overall is like let's use dancing as an example. The goal is to have people not think of it extrinsically like, oh, dancing is gonna be good for my health, so I should probably do it as a form of exercise versus intrinsically, oh, I really enjoy dancing. Like it makes me feel very happy when I'm doing it. Um, and the idea is intrinsic motivation drives people to stay with new behaviors more than extrinsic. So there are 5 A's you can ask to your patients to basically promote their adherence to the program that they're in. So first one is ask. So this is whether the patient is regularly physically active and satisfied with their physical functioning. So a good question for this can be, are you regularly active? Or, like we talked about last chapter, maybe describe what you do throughout the duration of a week. Like just explain it day by day. What do you do? Next, we have advice. So this is the patient or helping the patient pursue a more active lifestyle to maintain physical functioning. So a good idea for this as a statement can be continue your current activity, but try to take the stairs more often. So yeah, you're not discounting what they're already doing, but you're just saying, well, you could try this too, and maybe you'll see even more benefits. Um, and then we have assess. This is the patient's readiness to change, especially noting barriers to change. So, sticking with the stairs, are you willing to take the stairs every day? This is a pretty open-ended question. They could say, well, yes, well, no. Well, I work on the fifth floor, so no. Like it can help you kind of gauge where they're at. And then we have assist, in an active way to help find solutions to problems and overcome barriers. So here's another idea. Why don't you park your car by the entrance to the stairs? So that maybe they're not walking as much, but they are taking the stairs. And then lastly, we have arrange. This is a follow-up to ensure that the patient succeeds in being more active. I will email you on Friday for an update. So this is great because it's also a form of accountability for them. And typically for, starting different behaviors, if there is an accountability partner, in this case, it would be you, um, that can maybe help them adhere better. So that's the self-determination theory. And then we have two quick ones. So we have motivational interviewing. And this basically emphasizes the patient's autonomy and respects the patient's views. So what I mean by that is as they're talking through their problems or their barriers, the whole goal of this isn't to give objective values like, okay, you need to meet your 150 minutes and you have to lose 10 pounds. It's more so to have the patient feel like they're being seen, that they're being respected, and that they're just being listened to. And the book has this quote that says, motivation is often achieved through feelings, not by acquisition of knowledge. Now, I I wish we had a Likert scale for this. I feel like I mostly agree with this statement, and I'd be curious what you guys think too. Um, but I do think that this is very person dependent. Now, the book doesn't say this. This is just me saying it. Um, I know that I actually personally feel more motivated when I do have an acquisition of knowledge. Like the more I read about it, or the more classes I take and I learn about, different training methods that actually help people reach the goals that they want to reach, I feel like that's really motivating to me. But I can definitely see how it isn't for a lot of other people. So that's the whole idea with motivational interviewing. It's just very an open-ended thing. There isn't really a way to do this. It's just a way to I guess the point being that you respect where the patient is coming from. And maybe determining, if I'm right here and it actually does depend person by person, do they just need some support? And, have a feeling that they can do this to have motivation, or, would some objective facts of knowledge actually help them too? So that's up to you to determine. But yeah, I'd be curious to think if others also think the same thing about this quote. And then we have goal setting. There isn't really much to say about this because we all know what goal setting is. Basically, this is your weekly goal, 150 minutes per week of moderate to vigorous physical activity. Here's your goal. In 2 months, you will lose 10 pounds. Um, if we're talking more athletic, by the end of the year, you are going to run a sub 20-minute 5K, or you know what I mean? Just different things. However, there are some issues with goal setting that the book brings up. Often, I mean, this is the primary thing that specialists kind of set, right? Like, okay, we're meeting with this person. We're gonna set goals now. Like it always happens. It's the standard way of doing things in our field. And I'm sure all of you know that too. Maybe that's how you treat yourself whenever you're doing different exercises or trying out different sports or activities. You always start with setting a goal, right? Unfortunately, goal setting isn't always the best way to have people adhere to their exercise plans because of the main reason that if they don't achieve it, they feel like they're a failure. So, in response to that, here's another common behavior technique that contrasts with goal setting. So, we have self theory, which was developed by Carol Dweck, and well, I remember this was really big when I was in high school, which I guess is a little while ago now, but but she had a really good TED Talk, maybe a series of TED Talks if I'm remembering, where she talked about this theory. And again, not made with exercise in mind, but can apply very well to exercise counseling. So the whole point of self-theory is that prior experiences influence how people perceive themselves. So she defines two categories. There's people with fixed potential, and this is what they think. It's not like they actually are. Um, they think they have fixed potential, which is directly tied to their innate abilities, like what they can already do, what their limits are, so on and so forth. And then there's the group that is listed as unlimited potential. So they have the ability to master new things and don't really see any roadblocks in front of them. Um, so a lot of this relates to how people respond to failures in their lives. So, for example, let's say you have a patient, maybe, let's not even say patient. You're coaching someone. someone who's a high school athlete or something like that. They try out for a basketball team and they don't get in. Someone who has a fixed potential mindset would probably say, "Oh man, well, I'm like super skinny and I'm not very fast and I'm not strong. Like that's probably why I didn't make it." In contrast to that, someone with an unlimited potential mindset would say, "Oh man, I didn't make the team. I guess I just have to practice more." So, do you see the difference? One of them is essentially limiting themselves because they think, "Oh, it's things that like is a part of me and I can't change." Whereas the unlimited potential person can basically see themselves getting to that goal if they just try harder. So you can maybe tell which one's the more healthy one, right? The unlimited potential is the one that we want people to aim for. So often people don't develop these mindsets because they thought about it and they're like, oh yeah, I have fixed potential. It kind of just comes naturally, and maybe it just that's how they're conditioned to thinking. So it'll be your goal to try and change that in people and change them to a more unlimited potential mindset. So if we come back to our chronic conditions group, um, often some patients will come in with a mentality that, well, I have this condition and there's not much I can do to fix it. Now, to a certain extent, that may be true, right? Like a lot of different problems are not reversible, unfortunately. However, we know that exercise can help with a lot of it, whether it's just management or helping with the um, like dealing with the different side effects that they're having due to their condition or their treatment. Like there is stuff to improve, right? And if there's a lot of different pills that they're going to have to take, a lot of different medication, then exercise can definitely lower the amount of pills they can take. If not, it's not going to completely take them away from having to take medication, but it can help, right? So, so that's the whole idea of it. Now, a way to help coach people with this mindset is to help them focus on the process of learning new things instead of achieving specific goals. So, let's go to the you need to lose 10 pounds by, the end of 2 months, that example, right? If the patient is focused on just that goal of I have to drop 10 pounds before this deadline, and they don't meet it, then they're gonna feel like a failure, and maybe they're gonna revert to fixed mindset, a fixed potential mindset. Like, oh, well, I just love food too much and I can't control it, for example, or I just don't like exercising too much or limiting myself or restricting myself. Like they can go any number of directions in the wrong way, right? So if you help them just focus on maybe the process of exercise, like, you know what? Consistency is what matters and what you are feeling when you're doing exercise. That is what matters. Then they might actually get to their goal and it'll, it won't be the end all if they don't. So yeah, I like self theory. Um, I really like it, and I think it's good because it's something people don't realize that their mindset is actually limiting what they can do. So keep that in mind. Okay, and then we have a couple of minor things to talk about. So this isn't exactly a theory or a technique exactly, but it's more of another assessment. So we have the fear avoidance cycle. So this basically, I mean, it's in the word, in the name of the cycle, fear avoidance. So this says that there's this cycle where people usually who have chronic conditions or chronic pain tend to avoid things that cause that pain. And because they avoid it, then they basically they play it too safe, for lack of better words, and that leads to sedentary behavior and deconditioning, and then it just makes things go worse and worse. So often the catalyst for this is usually something like they have pain when they exercise, or they get injured, or they have a heart attack, or they have another near-death experience. And that causes them to have fear. And then here we have catastrophe ideation. So I'm sure all of us have experienced something like this, but you just think of the absolute worst case scenario of anything you're doing. And that causes them to be super vigilant, play it super safe. You know what? I just had a heart attack. I don't think I want to exercise because it's going to put my heart in a risky place and I don't know what's going to happen, right? So they just avoid exercise and as we know, things get worse and worse because they do that. So the main idea with this for you as an exercise specialist is that you have to go and basically see exactly where their fears lie. Oftentimes, and I guess this is a better version of it, oftentimes it's because of like false news that they've heard. Like a good example is, oh, exercising after a heart attack is not a good idea because you're overworking your heart. Well, no, we know that, right? As long as you keep the intensity low, monitor for any adverse events, and and yeah, just like, I mean, if it's so serious, if you do it with a person, like a specialist at your side, you're gonna be fine. And it's actually gonna help you with your condition. It's gonna help your heart, not damage it. So often, if you can just dispel that, that's a pretty good way to help them break out of this cycle. But often it's a little bit more serious, right? Like maybe, I mean, I wonder how you would deal with this, right? Let's say they were exercising and they had a heart attack. So the whole idea with this is you're just going to have to meet the patient where they're at, and you're going to have to help them kind of go away from this fear avoidance cycle. But to emphasize, I guess to clarify, it is a good thing to have some form of safety, playing it safe. It's good to do that, but doing it excessively leads to this cycle. So you can even bring up this cycle and share it and say, ultimately, this is what it's going to lead you into. If they're a person that can, take this well and yeah, and help them break out of this cycle. Okay, and then last couple of things are socioecological disparities and exercise and chronic conditions. So these are just four things to keep in mind, kind of along the lines of what we've talked about throughout this video. So psychosocial aspects, this is very basic, but it's just saying, um, what kind of things motivate your patients, or what are some of the backgrounds they come from? And I mean this more in an exercise sense. So we talked about extrinsic and intrinsic motivation, right? Um, where does your patient classify under that? Do they actually find joy out of exercising or not really. They're just doing it because it's good for their health, which is not bad, by the way. As long as they can adhere to their program with that kind of motivation, perfect. And another thing to consider for this is, um, do they like to exercise with people or do they prefer to do it alone? Some people, I'm sure many of you, only go to the gym if your friends go to the gym, and that's perfectly fine because you guys motivate each other and it's perfect. Some people refuse to go to the gym with others. Like it throws off their rhythm and throws off their routine. So learning all of that is a good idea as well, um, in order to guide your patients with chronic diseases. And then we have the economics of exercise, so cost versus benefit for the patient. So this is not much we can do about this exactly, but it's unfortunate because exercise has been shown to be a very cost-effective way to battle um, healthcare costs, right? Mainly through a prevention model, but also as a management platform. But unfortunately, exercise isn't very much emphasized in healthcare systems. So oftentimes, if people have to exercise, it has to come out of their own pocket, unless they're doing something that's very accessible, like walking or running or something like that. Um, so for patients who may not have as much money to work with, this actually might, it might not weigh very important to them. Like they'd rather not spend a limited amount of money that they have for exercise in comparison to other things that they have to spend money on. So that's just something that you're also going to have to kind of gauge as you talk to your patient. And then we have education, literacy, and health literacy. So higher health literacy can improve adherence. So we talked about this a little bit with the Carol Dweck's self theory model, but um, some people just don't really understand what their health condition means or what it implies. Most people definitely don't know what exercise can do for their chronic conditions, and you guys will know at the end of this semester. So, educating your patients is going to be really good for them in the long run. And as we see here, it can improve adherence to the workout plan that they get signed up for. And then lastly, we have, I think, a pretty interesting topic, spirituality. So, um, I had a professor who talked about this quite a bit because there's two ways that people can take it. So, first off, what we mean by spirituality, it can either be an organized religion that they're a part of or just a belief that they hold personally. Um, but you can take spirituality and use it as a form of motivation for people. Or sometimes they'll use that as a way of, not being motivated, or not doing what they should for their body. For example, there are thoughts in, let's just say the Christian belief that the body is a temple, so you should take good care of it, you should train it, you should steward it, with the time that you have available. So you shouldn't let it, waste away here. I have also met people from that realm of thinking that say, "Oh, well, this isn't really the end all be all, so it doesn't really matter what I do with my body. It's not going to matter. So why would I, you know, try and make it better?" So that's interesting, right? You can have two different mindsets to it coming from the same person. Also, the textbook notes that we should also be aware of some cultures or religions that actually look negatively upon exercise. I mean, there's some out there that whether it's an actual spiritual thing or it's just a cultural thing, they think, for example, oh, women like shouldn't exercise, they shouldn't lift weights or something. It's not natural. It's weird. It's, not the way it should be. So, just some things that you should keep in mind as you're working with different people from all across, any level of religion, spirituality, culture, socioeconomic background. Um, and yeah, so hopefully this helps. Hopefully this gives you a couple of tools to use with your patients. And yeah, I hope some of this was new and helpful.